Dear colleague, it's a real pleasure for me to be there today with you. I'm so sorry I'm not going to speak about the masturbation, but we're going to see about the breast implant associated anaplastic large cell lymphoma with the bioshell texture. Why this presentation? Because for a few years we can see in the literature some article about this disease with the biocell lymphoma, with biocell. And in France we have a mediatic crisis in 2015 with the Institut National du Cancer, who show an incredible increase of this disease. And a few days ago, the PRS released an article about this lymphoma in Australia and New Zealand. And the New York Times released a bomb, mediatic bomb, and released in their first page an article to explain how some breast implant can kill some ladies after a breast cancer. So the HISAP sent us a mail to explain how to react with this mediatic crisis. The aim of this presentation is not to explain to you the clinic or paraclinic of the lymphoma, because you are a surgeon, you know that. I'm not here to say if you can or cannot use biocell or polyurethane or other. I'm here to understand why we have some oils here with biocell texture, and we'll see if it's possible to prevent them. To answer to this question, we realized the complete literature review and the scientific study with statistical and microscopic analysis. First, the most important with the biocell texture is to understand the texture, because we have some characteristic. With the biocell, we have real pores with diameter and depth, and the depth of pores, this diameter, allowed the growth of the capsule into the prosthesis, and we have mirror effect. And little by little, we can have an attachment, a real attachment between the capsule and the prosthesis. And Professor Danino called this attachment a real Velcro effect. This Velcro effect allowed the friction coefficient more important with biocell, because the microtextured biocell is very rough. We can see some modification of the chemical properties of the silicone, because we're going to have an accumulation of silanol on the textured surface with an electrostatic attraction at the origin on an inflammatory reaction on the surface. So with the Velcro effect, with the accumulation of silanol, we're going to have a chronic mechanical inflammation. But it's very important to understand the biodynamic too. The biodynamic with the biocell is very important, because with the Velcro effect we have a real attachment in anterior and an attachment in posterior. But when you move, we're going to have a traction in anterior and traction in posterior. So with this antagonist movement, we can have in some cases some implant rupture. But in some cases, when you analyze a capsule with a microscope, we can see some layers, and little by little, between this traction anterior and traction posterior, we can have a split, a real capsular delamination. And if we analyze this bubble on microscopic analysis, we can see some bubble. These bubbles are the sign of the anterior-posterior traction. When you put an implant, we have an immature collagen, and under the Velcro effect, under the traction, we're going to have a capsular delamination and the formation of double capsule. It's very important to see we don't have any double capsule with the smooth patch on the posterior. And with the double capsule, we can have that are called chronic dynamic inflammation, and the double capsule and the seroma, who call biomechanical seroma. With the biodynamic, we have the biofilm. The biofilm is very important because the biocell can change periprosthetic characteristic. With the architectural characteristic, with the mirror effect we saw, we can see a vascularization. This vascularization is very important, specific with the capsule around the biocell. This vascularization is important because when you have a split on the capsule, we're going to have an extravasation. We can see on microscopic analysis some silicon particles on the capsule, because with the Velcro effect and when we have a traction, maybe silicon particle can be thrown to the implant in the capsule. And if you have some particle, foreign body, we're going to have some inflammatory granulomas with macrophage. We can see some bacteriological characteristics, very important because Deva used this theory for this news article. Danino showed with Pure and Peak that we have an increase in the number of bacteria with the biocell, with the polyurethane tube, because we have a higher surface by the pores. We have a faster bacterial development and a stronger bacterial attachment at the origin of the biofilm development. There I show, with the bacteria, we can have an increase of the bacterial contamination and an increase on the T cells response, and we can have some CD4 augmentation. The CD4 are the T helpers. So with the augmentation of bacteria, we're going to have an increased T cell response, like a T cell hyperplasia with a chronic antigen stimulation. And they compare this problem with the gastric lymphoma, with the Helicobacter pylori. When you have a chronic inflammation with bacteria, we can have deregulation of T cell stimulation and a maladaptive immune response at the origin of a chronic immune inflammation and a seroma, a biofilm seroma. Our theory is we have biofilm, we have biodynamic, but it exists a real interaction between biofilm and biodynamic in the biofilm development. Because in our study, when we didn't have any problem with the biodynamic, we didn't have any biofilm. So it exists a real interaction between biofilm and biodynamics with the biocell. The late seroma, we have the biomechanical seroma, the biofilm seroma. And in the literature, the late seroma is very often associated with a microtexture, very often associated with double capsule, because the origin of late seroma and double capsules are very, very similar. So how to prevent this ALCL? Maybe we can prevent the biofilm formation with anti-infective strategies. No use the areola. Maybe we can use other antibiotics, povidone, not touch. It's very important to protect our implant. But when you read the literature, you see there are a lot of lymphoma with aortic prosthesis, with orthopedic prosthesis. And when you see some orthopedic surgeon with hip prosthesis surgery, it's very difficult for me to say that, but plastic surgeons looks like a Flintstone. So maybe we have to change our practices. We can prevent maybe dynamic problem. Danino showed that post-operative strict immobilization decreases the risk of problem. Maybe if you want to use an anatomic implant without rotation, we can use a bitexture implant with an anterior adhesion attachment with a posterior mobility, like a natural breast with a chestnut space in posterior and creston durée in anterior. With this implant, maybe it's a theory, we can decrease the biodynamic problem and maybe decrease the biodynamic biofilm. To conclude, in summary, that take-home message, with the biocell implant, we're going to have a chronic mechanical inflammation with the silanol accumulation on the surface. With the anterior-posterior traction, because we have a Velcro effect, little by little, we're going to have a capsular delamination, and it's a chronic dynamic inflammation. The split of the capsule is at the origin of extravasation and the creation of a biomechanical late seroma. And in this seroma, we're going to see silicone, macrophage, bacteria, gram-negative. We're going to see some inflammatory factors and overall T cells and CD4. So with the chronic mechanical dynamic immune inflammation and with genetic predisposition, I think we have perfect condition to have a breast implant associated ALCL. But in this new article, we can see a higher risk of ALCL with the polyurethane. I think it's very important to see other article, and we're going to speak about this problem Saturday morning. Enjoy your trip in Marseille, enjoy your congress, and thank you very much.